You know, when you think of an operating room, you think of absolute control, right? The temperature, the tools, the team, every single thing is precise. But what if I told you that sometimes the biggest threat isn't a scalpel or a complex machine, but something as simple and as essential as water? We're going to start with the scenario that plays out in hospitals every single day. It's a standard procedure, one that's designed to help. But on this particular day, it spiraled into a life-threatening crisis, and it all happened in the blink of an eye. So, let's meet our patient. She's a 54-year-old woman weighing just over 44 kilograms. She's coming in for a hysteroscopic myomectomy, which is a really common way to remove uterine fibroids. Everything looks routine. Everything seems totally fine. All right, Section 1, a routine procedure. Now, to really understand what went so wrong here, we first have to look at the initial plan. And honestly, on the surface, this is a totally standard setup for a very common gynecological surgery. Here's the pre-op checklist. The patient's stable, she's under spinal anesthesia. Now, I want you to notice two really key details here. The team is using a monopolar resectoscope, that's an electrical tool for cutting, and they're using a hypotonic irrigation fluid. That's basically just electrolyte-free water to keep the surgical field clear. Now, these two choices, while pretty standard for this kind of setup, are actually the critical ingredients for the disaster that's about to unfold. So, the surgery begins. The surgeon's working, the team is focused, but then the first subtle signs of trouble start to appear. And because the patient is awake from the spinal anesthesia, she's actually the first one to sound the alarm. Just look at how fast this all collapses. It starts with her feeling restless and a bit nauseous, but then, very quickly, she's confused and in pain. Her blood pressure shoots up, then completely crashes as her heart rate slows way down. And then, the most terrifying sign of all, frothy pink fluid appears in her airway. It's acute pulmonary edema. Her lungs are literally filling with fluid. The surgery is stopped immediately, and she's rushed to the ICU. So what on earth just happened? How did a routine fibroid removal turn into a full-blown systemic crisis? Well, the answer lies in a toxic interaction between that irrigation fluid and the patient's own circulatory system. The diagnosis is TUR syndrome, or as it's often called in gynecology, OHIA syndrome. This is a classic, though thankfully rare, complication where the fluid that's supposed to be clearing the surgical field gets absorbed in massive quantities right into the patient's bloodstream. This whole thing is just a devastating chain reaction. So during the resection, uterine veins are opened up. That hypotonic irrigation fluid, which remember is basically just water, rushes into her circulation. This instantly dilutes her blood, causing her sodium levels to plummet. That condition is called hyponatremia. This huge imbalance forces water into her body's cells, causing them to swell up. When brain cells swell, you get the neurological symptoms like confusion. When the fluid overloads the heart and lungs, you get that catastrophic pulmonary edema. And this right here really illustrates the root cause of this whole mess. Monopolar energy, the kind they used in this case, requires that electrolyte-free hypotonic fluid to work. It just won't function without it. Bipolar energy, on the other hand, works perfectly fine with normal saline, an isotonic fluid that's very similar to our own blood. So by using saline, you dramatically reduce the risk of this dangerous sodium dilution. I mean, sure, fluid overload is still possible, but that life-threatening hyponatremia is pretty much taken off the table. It's a real game changer. So this brings us to the most important part of this whole discussion, prevention. Because this entire crisis was avoidable, and understanding the risks ahead of time is absolutely key. Okay, here are the major red flags. We've already talked about the danger of monopolar energy, but check out the others. Any procedure that lasts longer than 90 minutes, removing a large amount of tissue, and using high irrigation pressure all dramatically increase the amount of fluid that can be absorbed. Seeing these risks beforehand is everything. And we've got solid data to back this up. A major study looked at patients who developed symptoms of TUR syndrome versus those who didn't. Just look at those p-values on the right. They're all less than 0.001, which means these differences are highly statistically significant. The symptomatic patients had longer surgeries, more tissue resected, and a much, much larger drop in their sodium levels. It's not a coincidence. And that brings us to the single most powerful predictor we have. That same study found that a drop in serum sodium of over 7% from the patient's baseline is a massive warning sign. This simple percentage can predict the start of clinical symptoms with really high accuracy. It's a number that every single person on a surgical team should know. But what happens when prevention fails and the crisis hits anyway? The response has to be immediate, it has to be organized, and it has to be precise, because the team's actions in the next few minutes will literally determine the patient's outcome. Okay, so the treatment path you take depends completely on how severe the situation is, and that's all gauged by the sodium level. If the drop is mild and the patient is stable, you can be conservative. Restrict fluids, maybe give a diuretic. But if that sodium level is below 120, or the patient has severe symptoms like in our case, the response has got to be aggressive. Immediate administration of 3% hypertonic saline. So here is the clear 4-step emergency protocol. First things first, stop the source of the problem. That means turn off the irrigation fluid and end the surgery. Second, give a bolus of hypertonic saline to quickly start raising the blood's sodium concentration. Third, protect the airway. With pulmonary edema, that patient is going to need oxygen and probably intubation. And finally, once you stabilize them, the correction has to slow way, way down to prevent a different kind of neurological injury. And this quote explains that incredibly careful balancing act. Correcting sodium too quickly in a chronic case can cause a devastating neurological condition called CPM. But, and this is a big but, in an acute crisis like TUR syndrome, the immediate danger is brain swelling from the hyponatremia itself. The consensus is crystal clear. You treat the immediate life threat. The risk from the brain edema is greater than the risk of CPM. Wow, this case is such a powerful reminder that even the most routine procedures carry these hidden risks. So let's just distill this all down to the most important lessons we can take away. Here are your 5 key takeaways. Number 1, choose polarized bipolar. Whenever possible, use bipolar energy with normal saline to slash the risk. 2, mind the clock. Keep that resection time under 90 minutes. 3, monitor your fluid deficit obsessively. If you see that hypotonic fluid absorption has gone over 1,000 ml, you stop the procedure. 4, watch the sodium. A drop of more than 7% is your critical warning sign. And 5, if crisis strikes, act fast with hypertonic saline, then correct slowly and carefully. And that brings us to our final question for you to think about. After reviewing this case, if your next patient has multiple risk factors, maybe a large fibroid, or an anticipated long surgery, what 3 concrete changes will you and your team make before you even begin? Because that proactive planning, that's what turns a potential crisis into just another routine day in the OR.